You guys were awfully quiet. I don't know if that's a good thing.
Probably all hungover.
On a Sunday.
Oh no, what is that?
What is what?
Hungover.
It's not a matter of being hungover. It's a matter of being hungover on a Sunday.
Any Monday?
Oh, okay. On a Monday morning. Getting drunk on a Sunday.
Life's too short, Lou.
Yeah.
You
That's why you need to spend it sleeping. Especially when you get to be my age. So, all right. 30 minutes just to take a quiz is a little long. And then I was getting ready to start and I noticed people weren't in and then coming in and leaving and all this other stuff. So, yeah, unfortunately, I can't kill the test at 15 minutes. Actually, I think I can now. I'm gonna start doing that. But remember, class starts at 8 o'clock.
You gonna start doing what?
Limiting the quiz to 15 minutes. If you're not done by 15 minutes, I'm sorry. Because everybody, or not everybody, but a lot of people like to be late to take the quiz, and it pushes everything back. So there's another quiz we won't review because it used up too much time just for people to take it. So anyway, so chapter 30. So today we got musculoskeletal injuries and head trauma, and that's kind of why. Got 2 chapters, although it's not going to be too bad. And some of the stuff that we'll talk about musculoskeletal about is having to do with with the bone, but there's soft tissue involved also. And so there are some things that we talked about the other day, such as open and closed is also with musculoskeletal injuries. All right, so 45-year-old Dominic Foster rushes out the door of her office building, running late as usual, she thinks. As she steps off the curb onto the parking lot, she slips on a patch of ice and pitches to the left. Her left arm shoots out reflexively to stop her fall. As she lands on her outstretched hand, Dominique simultaneously hears and feels a snap just above her left wrist. So what are some safety considerations for you and the patient in this scenario?
Circulation.
Safety.
Just watch out for the ice.
Ice, weather. Mm-hmm. What signs and symptoms should you look for in your assessment? If somebody just fell down and went boom, even forgetting about the fracture, what are some of the things that persons can be experiencing? And now you throw in the fracture.
Pain, swelling.
Bruises.
What was that?
I said bruises.
Bruises, okay.
And someone else said pain and swelling.
Okay. So do you guys remember when we went over patient assessment? What is it that we're looking for in our assessment? Our secondary assessment.
The significance of the injury?
In our secondary assessment.
DCAT BTLS?
All right. What does it stand for?
Deformities, contusions, abrasions, punctures, penetration, burns, tenderness, lacerations, and severity?
Swelling.
Swelling. My bad.
Yeah.
That's so be curious too.
So, again, what are signs and symptoms should you be looking for in your assessment?
The deformities for that one.
Cat BTLS.
Yeah.
See how it works? No, it's not a beer.
You sure, Lou?
We had about a third of a beer last night.
Nice.
All right. So, you said lies?
I said nice.
Mm.
Chicken bite.
So, just like soft tissue injuries, musculoskeletal injuries can be very graphic. They can be life-threatening, but they could also be minor musculoskeletal injuries. Remember, it's not just the bone itself, it's other tissue as well. So, for example, if you jam your finger and it just hurts, that's a minor injury. But if you have a fractured pelvis or bilateral femur fractures, those could be life-threatening. So, really, our goal when it comes to treating musculoskeletal injuries is going to be preventing further injury or further harm. And we accomplish that by mobilizing the patient. And you guys went over that on Thursday and Friday. So let me see who's here. I see darkness in somebody's doohickey.
That's me. Just too bright.
Now you see a little bit of glare off the forehead.
Thanks, Lou.
You're welcome. Where are you at, Miss Rosie?
I'm here.
Mm-hmm. So anyway,
Partially here.
Yeah, I'm not all here.
so Mr. Andrew,
Yes, sir.
I forgot my question. All right. What are the functions of the musculoskeletal system?
To give the body some shape, to provide the internal organs, to protect the internal organs, for movement, the storing of salt and minerals needed in the metabolism, and to protect the red blood cells necessary for oxygen.
Did you read that off the book or did you know that?
It's right there in the book.
Cool. All right. So as far as muscle goes, actually, let me do this. What types of muscles are there? Ms. Minna, what types of muscles are there?
There's voluntary, involuntary, and cardiac.
Okay, give me an example of involuntary.
That's like your
Your lungs.
Are the lungs considered a
Or
muscle?
no, the never mind.
Miss Ashley, give me an example of an involuntary muscle.
Is it like, oh, the movement in your hands, like it's involuntary? Like, no, never mind.
Involuntary is when they're found in the walls of the organs. It's like moving food down from your when you're eating food and it moves it down.
So like your esophagus.
I see. I have one.
All right, so which muscle? You're right, that's the action, but which muscle is that?
The esophagus.
Or what structure? Yeah, the esophagus. So the esophagus is an example of a smooth muscle. So are the intestines. Bronchial smooth muscle, that's another one. It's involuntary, we don't have to think about it. All right, and then lastly, we have the voluntary muscle or the skeletal muscle. Now, with those muscles, with the skeletal muscle, obviously we need nervous control, right? And what's really the action of causing those muscles to work?
The brain.
Okay, I said action, not structure.
Oh, sorry.
That's okay. It is the brain that sends the signals to the muscles to do what they want, what it wants to happen. It's contraction and relaxation. Remember, like with respiration, contraction and relaxation, active and passive process.
Yeah.
So the muscles are going to contract to get something done. For example, when you extend your arm out, your triceps are pulling while your bicep is relaxed. Now to flex, it's your bicep that's contracting and your triceps are relaxing. So it's a counterbalance there. But yeah, it's a matter of the muscles contracting and relaxing in order to cause the action that we want. Now, we hurt ourselves. What are some of the injuries that we're going to get with with the muscles?
like strains
Pull
and
muscles.
Okay.
When you pull muscle.
Do what? I'm sorry.
You could get the hamstring strain, calf strain, groin strain,
Cramps. When the,
a rupture of a long head
un
bicep,
calambre. ¿Cómo se dice?
pulling a muscle, in other words.
Okay. So you could pull a muscle. It can cramp. It can tear. It can be crushed. Will cause bruising.
You can stretch it.
You could overstretch it. Okay. So there's connective tissue involved as well. What is that connective tissue in the body responsible for movement?
Oh.
Tendons,
What was that?
tendons,
And
ligaments,
ligaments. What's a tendon?
connects muscle to bone,
And what's the ligament?
Bone to bone.
bone to bone.
Okay. What type of injury do you sustain when you injure a tendon?
A torn
Dislocation.
tendon.
Okay, I can't decipher two people talking at once.
I said dislocation.
Yes.
That's at a tendon dislocation? Thought that happened to bones.
Like a
Oh,
sprain?
tendon.
A hyperextension,
Okay. What do you mean like a sprain?
A sprain.
Is it a sprain or is it not a sprain?
It's a sprain.
No, it's not.
Ah.
Anyone else?
a hyperextension,
Nope. I mean, that could occur as well, but that can occur with anything. What kind of injury if can occur to tendons? Strains. Just remember the T in strains equals the T in tendons. And so now, with ligaments, what kind of injuries can you get? If it's not strains,
Dislocation.
with ligaments? How can you
Yeah.
dislocate a ligament?
Never mind.
a sprain,
There you
You
go.
can tear
Sprains
it?
do. Uh-huh.
Oh, nothing. I was like, tear it?
Yeah, you could tear it as well, but when we're talking about ligaments, that's a sprain, and really, their overexertion, overstretching, and even tearing of these connective tissues. What's the other connective tissue we have?
Cartilage.
Cartilage. What's the purpose of cartilage?
Doesn't it help to keep your bones from like grinding against each other?
Yes, it acts as cushion. It helps with reduce friction. Acts as a shock absorber. Okay. So now, so that so that's the muscle part of it. This is kind of taking you guys back to chapter 7. Give me terms and definitions. Actually, I take that back. Josh, tell me what flexion is. Define it for me. Angel, define flexion for me.
Define what?
Flexion.
Mm. Would it have to do with like movement?
What movement?
Of the body? Like, no, that never mind. That'd be
Like a limb?
Like a limp? No. Okay. So Josh says, like flexing biceps. Okay. So if I don't know what flexing is, what would you guys tell me?
The contraction of a muscle.
Any motion moving.
Isn't like bending of the joint?
yeah, like a bending motion.
Towards the body.
A muscle serving to bend body part.
Bending of the joints.
So if you could see me, if my head goes back like this, or actually no, if I go like this, what did I do?
You bent your neck.
But that's not a medical term.
You flex.
You
Did I flex or did I extend my neck?
You flexed.
You extend.
Extending it would be the way you did it the first way.
If I go like this, did I flex or extend my neck?
Flex.
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 It's extend.
Flexion, remember I told you guys, flexion is where you make the angle smaller. So the flexing the biceps, yeah, that's the example I gave you. But why is that flexion? Because this is extension. Flexion is making, you see the angle right now, it's 180. But now I just went 90, 45. I just decreased that angle. So making the angle smaller. So what's the curvature of the cervical spine? Is it convex or concave?
Spine is convex
Okay.
because you're extending it forward.
So in which direction, if it's convex, in which direction do I need to go to make that angle smaller?
Concave is to bend back. The other one is to go forward.
No.
No? Because concave is making it smaller, right?
No.
No.
Okay, so here's the here's the angle of the back. So here's convex of the neck, concave of the thoracic spine, and convex of the lumbar spine. So here's my head, there's my nose right there. There's my beak. So if I go down, remember there's the angle. Am I making that angle smaller or bigger if I'm going this way?
Smaller.
No.
Bigger.
Because here's the angle. There's the angle. So if I bring my head down this way, did I make my angle smaller or bigger?
Bigger.
I made it bigger.
You're stretching it out. Or stretching it out.
Now if I go back, so small. All right. I feel stupid. You guys are right.
Yeah, right.
Anyway. Yeah, the forward is hyper
Extension.
Yeah, the forward is a hyperextension. Wait.
Yeah, because you're extending it.
Yeah, going forward is hyperflexion. Right. Yeah, going forward is hyperflexion, going back is hyperextension. But the other stuff remains true though. Whenever you make the angle smaller, that's flexion. I can't even see. So you are making the angle smaller from the chin to the chest. Anyway, so we have hyperflexion. Ugh. We have flexion and then extension. All right. What's abduction?
You said ad or ab?
Abduction.
Ab.
Is that like away?
Okay. Away from what?
Okay.
The midline of the body.
Yeah, you're just moving it away from the body. Whereas adduction would be what?
Body part towards the
Towards the
midline of the body.
Moving it closer to the body.
Alrighty. All right. Did we talk about the axial and appendicular skeleton back in the human body?
I think so, yeah.
Okay, so what's the axial skeleton? And don't tell me the structures of the axial skeleton. Tell me what the axial skeleton is. In your own words.
Like the head, body, and lower extremities.
No.
Are you asking like what they compose of, or?
No, I'm asking for the definition of the axial skeleton. The axial skeleton is the skeleton that goes right down the axis of the body. Whereas the appendicular skeleton is the appendages or your extremities, including the pelvis. Does that sound familiar?
Yeah.
Yeah.
All right, as far as the bones of the body that you need to know, clavicle is an important one. The scapula, the humerus. Actually, all those right there. I take that back. You don't need to know the olecranon. That's just the part of the ulna that helps create your elbow joint. It's how the ulna glides with the elbow in order to be able to go to extend and come back to flex. Radius ulna, yes. Carpals, metacarpals, phalanges. So all of them except the olecranon. Lower extremities, the pelvis, the femur, the patella, the tibia, the fibula, and then the bones in the ankle, whereas the in the wrists are called carpals, in the ankles are called tarsals. And then you have your metatarsals and finally your phalanges. And your phalanges you have both in the hand and it's your fingers and toes are the phalanges, the different bones there. More specific structures you don't need to worry about. So, I mentioned earlier how we have injuries with soft tissue injuries, right? We have open and closed, correct?
Yes.
Okay.
Yes.
Now, as far as the musculoskeletal system, we also have open and closed. And we even have a combination. So the first one is called a fracture. And this is injuries to the bone or to the joints themselves. So a fracture is where there's a break in the skin. I'm sorry, I take that back. When there's a break in the bone, there's the continuity of the bone is affected. And with that one, like I said, it could be both a closed injury and an open injury. An open injury, or it's called an open fracture, which we used to call a compound fracture, but now we call them open fractures.
The break of the skin.
What was that?
The break of the skin.
Yeah, where there's actual break in the skin, just like with soft tissue injuries. There's a break in the skin. Now, what can cause a fracture?
A lot
Fall.
of things. Yeah, fall.
Okay, I'm not talking about, well, I am talking about mechanisms, but not talking about specific mechanisms.
Car crash. Like you can break it with your legs from like the pressure of the steering wheel or something.
No,
That's
well,
mechanism.
what I was referring to is a direct force, an indirect force, or a twisting force. So direct force would be the baseball bat to the ribs. An indirect force is where the main part was somewhere else, and it traveled up. And twisting would be like taking somebody's arm and twisting it. Those fractures do occur when you're wringing someone's arm and cause a fracture. So, signs and symptoms of a fracture.
Pain.
Okay, pain,
Deformity.
deformity,
Swelling.
tenderness, and swelling.
Inability to move it, your hand or muscles or
Okay, inability to move the injured area.
Weakness.
Okay, weakness. Loss of sensation. Loss of circulation.
Yes.
All right, so here are the different types of fractures, not just the forces, but different types. We have comminuted, where it's just multiple little fractures that occur. You have impacted, so coming down, going up, compresses it. There's an impact there. There's a green stick where there's a splintering of the bone.
how do you get
Yes.
that?
Huh?
How do you break a bone like that?
It's an incomplete fracture.
Hmm.
I'm trying to remember. Extending hands on a fall. Here's the spiral, the twisting. And then transverse is straight across, complete fracture.
Have you seen all these fractures?
No. They even have pathologic ones where disease process weakens the bone, and they could include bone cancers as well. And it becomes weak, and they step wrong, and all of a sudden now they have a fracture. All right, we talked about
It says that it typically affects women more than men. Like after menopause.
what, the pathologic or which one?
Yeah.
Well, because of osteoporosis. So yeah, the bone becomes brittle, but I'm just letting you know also that bone cancers can cause it. But yeah, no, osteoporosis is also considered, it's a pathology, it's a disease process. So yeah, they could step wrong, you look at them and they break a hip.
I wish that was the case.
Just you wait. You'll be there in about 5 years or so.
No, I'm saying like just giving my residents a dirty look that I can. Some of them are a pain in the ass.
Well, what, women or men or both?
Both.
Okay. Women more than men?
I would say men.
So you see, does that look normal?
No.
No.
Gnarly deformity? Although I would have to see exactly how the break is, but that's a tibia right there. And that looks like the malleolus and everything else. So without looking at it, there's a gnarly dislocation, if anything. But who am I to say otherwise? Now here you go. Here's the heel. Open or closed fracture?
Open.
Open.
Open. Remember what I told you guys, that they could be very graphic, but both soft tissue and the musculoskeletal. But if we get that patient, what's our priority?
To stop the bleeding or their airway.
Okay. Do we really have to worry about airway for this injury, though?
No.
No.
No. Just
It's
prevent further damage.
Yep. Unless it's affected the posterior tibial or the dorsalis pedis. Yeah, we would worry about that. But remember, what is the goal of musculoskeletal injuries and the goal of soft tissue injuries? The goal of soft tissue injuries is to prevent infection, whereas the goal of musculoskeletal injuries is what?
Prevent further injury.
Further injury. Because you have a broken bone and you're moving it about, what are you risking?
Blood loss.
Further injury.
Oh, yeah.
So here's two bones and they break and I'm moving them. What am I doing?
causing pain.
Well, it's going to be pain, but remember, I have two sharp edges. They're moving around where there's muscles, ligaments, tendons, blood vessels, nerves. So what am I doing? Risking severing other structures, cutting them up, slice and dice. So we want to mobilize it to prevent further injury by making sure they cannot move it. We would cover it up to prevent infection. This is an open wound. Gnarly deformity? I had a kid, football player. He comes to the sidelines and his arm looks like that, and he's like, "Here, let me go back in." I'm like, "No." Okay, so with fractures, we're worried about, as you guys mentioned, bleeding control, blood loss. We're also worried about loss of blood supply. We're worried about nerve impingement. So what do we do before and after we mobilize the wound or a injured extremity?
Check for PMS.
There you go, which stands for?
Pulse, motor, and sensation.
Okay, motor function and sensation. Yes. Oh. Okay. So we talked about strains. We talked about sprains. What's a dislocation?
When a bone comes out of its place.
All right. Where the bone is out of its place within the joint. So you saw that previous picture with the bone sticking straight out, but not through the skin. So this is the knee right here. What do you think? So here's the femur, the tibia, and the fibula.
Ouch.
Uh-huh.
Pretty sure that's painful.
Yeah, and what else you have to be concerned about besides the dislocation?
The blood vessels, because they can
Blood loss.
Okay, so you said blood vessels. Because why, Sequoia?
because it could be dangerous because it could damage like the nerves or the pairing or like compressions or something.
Okay. So as far as blood loss, why do you say blood loss?
Because it damages some. If something like that happens, that it damages the blood vessels, and so
No, but
like
I want to hear the person that said blood loss. I want to hear why they said blood loss.
Oh, that was me.
Okay, why blood loss?
Because it's a broken femur, so you could lose about like a lot of blood. Like,
But this is not a fractured femur. This is a dislocated knee.
Porque la venita que le manda la sangre a la de esta está like it could be compromised.
Is it a vein?
Yeah.
You sure?
An artery.
Which artery?
Someone can help me out.
No.
Femoral. Oh, my bad.
Did somebody say? I didn't hear.
Femoral or something.
It's the what? I heard femoral, and I don't know if that's true. But that's correct.
Could it possibly be towards like the tibia area? If it was artery, like if it's not femoral.
it would be the popliteal vein. It's
Oh.
is that what you're referring to, Lou?
Kind of, sort of, not really. It's not the popliteal vein. It's the what?
Popliteal artery.
The popliteal artery.
Close enough. Close enough.
So. All right. So as far as taking care of these wounds, what's the first thing we want to do?
Would it be elevated?
Okay, what else?
Stabilize it from moving any further.
Okay, what else?
Would you actually put it back in
To
place, or
pop
you
it back in
just?
place? Oh, yeah.
Okay, so for dislocation, is that what you're referring to?
Yeah.
Okay. How?
Without saying pulling it, because that doesn't sound like, death, but I don't know.
Yank it out first, and then you
Grab, like, yank it, pull it forward and a little bit to the left.
Oh, you're getting really specific there. Anybody else?
You want someone to hold the patient, and then you like grab it in a secure way, and you pull it, and then put it to the straight. If that doesn't work, secure the leg.
Okay, and when do you apply traction?
Not sure.
Whenever there is a dislocation, we do not apply traction to it unless you have neurovascular compromise. In other words, if there's numbness or tingling to the area distal from that from the injury, or you feel no pulse, then you apply unilateral traction. In other words, in one direction, and you do it once. Don't do more than that. Unilateral traction in one direction. That's it. Then hightail it out of there. Okay. All right, we talked about femur and pelvic fractures in the past. We know that we could lose a lot of blood, a lot of fluid as a result of that. And here's a diagram why, and again, this is in your book. So you see all that vasculature, not only with the bone marrow, but you have the arteries going through the bone within the shaft of the bone, long bone in this case. And then you have the blood vessels up on top and the bottom in the spongy bone of the bone. Okay, so it is very, very vascular. Um, all right. Unless there's a really obvious deformity, how else can you diagnose a fracture?
Wouldn't it just be by the look of it?
Well, now there's another way, because you might see the obvious deformity, but what if you don't?
It would be bruising or it'll be hot to touch.
Hot to touch.
Signs of shock glue?
Are all fractures going to give you signs of shock?
No.
Crepitus?
What?
Crepitus?
Crepitus. What is crepitus? But no, that's not the answer. What is crepitus?
The sound or like feeling that a bone, like bone fragments.
Okay. What about them?
They're grinding against each other.
Okay. So you have two bone ends that are grinding against each other. That's crepitus. An x-ray. Unless it's an obvious deformity, the only other way to tell is through an x-ray. It's kind of a trick question. All right, we talked about the decap BTLS that you'll see there. They'll have the 6Ps. That's not something you'll normally get tested on. All right, so I hurt my forearm. And you see me holding my arm. So what are you going to do?
Stop that yawning, Blue.
I do yawn.
I said stop yawning.
I can't help it.
Stabilize it.
All right. So you want to stabilize it. What else?
Do I go like step by step? Because I remember we did something like that with Thursday.
Mm-hmm. Okay. So you get your partner to mobilize the injured area or the injured extremity, whatever the case is, and then you're going to check PMS. Now, I injured my forearm, my medial forearm. What's the rule as far as what you're going to immobilize with a medial forearm or anywhere that's not a joint? Did they cover that?
Not really. We just kind of went over the different splints.
Okay. So what you immobilize when it is not a joint is the joint above and below the injured site. So if this is where my injury site is, what do I need to immobilize?
The elbow. Oh.
Wouldn't it be
The wrist and elbow.
There you go. So the elbow and the wrist, because it's the joint above and below the injured site. Now, if it is a joint that is injured, what must you mobilize? The area above and below the injured site. So if I injured my wrist, I'm gonna mobilize the hand and below the wrist. So just basically this area right here. Whereas if it's my like medial forearm, then it would be my joint above and below the injured side, so my wrist and my elbow. You see that? So if it's a joint, what do I need to immobilize?
Above and below the injury.
Okay. So just remember, guys, you're going to mobilize the area above and below the injured site. So you got to give descriptors. All right. If it's not a joint, then what do you do?
Immobilize above and below the injury.
But isn't that the exact same thing we do with non-joints? I mean, with joints?
Is it elbow to wrist?
Mm-hmm. So you mobilize the joint above and below the injured site. Joint, no joint. Vice versa. And so you're putting on that splint. What else might you do to help me?
Apply some cold packs.
Okay, good. We're going to apply a cold pack. Why?
To try to alleviate the pain and reduce some swelling.
Okay. So have you ever put your hand inside a big bucket of ice? And after a while, the ice starts to melt and it creates ice water?
Yeah.
What happened to your hand when you brought it out?
Numb.
It tingled or kind of like,
Yeah, it feels all tingly.
Numb?
yeah.
Yeah.
Yeah. Sorry, Luis, I was asking the alcoholic.
Wow.
I mean, the
don't know.
one experience with alcohol.
I don't know what you're talking about.
You weren't showing pictures of all the booze around you at home.
That was not recorded, so I don't know what you're talking about.
No proof of that.
Yeah, there's no proof.
Now, why does it reduce swelling? Or minimizes swelling? What does the ice do? What does cold do?
Constrict the blood vessels.
Do what?
Constrict the blood vessels.
There you go. Constricts blood vessels. And so it's reducing the amount of fluid going to that injured area. So when you are reassessing your patient, whether it be every 5 or 15 minutes, remember we reassess vitals, but what else do we reassess?
Pulse, motor function, and
So we
sensation.
reassess EMS, and what else? we want to reassess the intervention. So that's part of the PMS part of it. We want to make sure that it's not too tight, it's not too loose. They're not experiencing any numbness or tingling. So look at their fingers. Ask them, is there any numbness or tingling in your fingers or toes or wherever? Okay. So as far as splinting, you look so comfortable, Sequoia.
I am. I got my little
Is that
one.
your dog you're cuddling?
Yeah.
Kind of looks like a little pillow.
That's a little dog?
This is my big pillow to cuddle with.
I don't know what you guys are going to do if you ever have to go to class. Other than just skills. Okay. So as far as splints, here's the thing I always say about splints. You could really use anything as a splint. It doesn't have to be a commercially produced splint, like a sand splint or a cardboard splint, vacuum splint. You could use just about anything. You could use pens, pencils, newspapers, umbrellas, canes, towels, sheets. There's a lot of options. There's a few rules when it comes to splinting, but the big ones are PMS before and after splitting. There is what you immobilize. If it's not a joint, it's the joint above and below the injured site. If it is a joint, then it's the area above and below the injured site. Other than that, not a lot of rules. So again, what we're trying to do is we're trying to prevent further injury. And like I said, we want to make sure that the area is not getting injured by the broken ends, by it's not going to slip and actually now cause a dislocation or compromise neurovascular status. Other complications, no, we already talked about. So you see here how they show up to the injury site. They took off his shoe and sock. It's not like he was there without his shoe and sock. You see the wound over the pant leg.
Yeah.
Okay. So that's why they're checking distal PMS. Now, the only thing I would say here is remove both shoes and socks, or shoes and socks on both feet. That's the only thing I'd do different there. All right. Is there a lot of bleeding?
No.
Doesn't appear to be. So what's the next thing we're going to do?
Bandage.
All right, we're going to expose it. Are we going to do a bandage first?
What do you want? You cut it like the
A dressing.
Apply the dressing first. And then a bandage. What's the definition of a dressing?
It's to keep the bacteria out.
It's something that's sterile or as clean as possible that's applied directly over the open wound. Now what's the definition of a bandage?
To hold the dressing in place.
Something you.
Somebody was saying it.
To hold the dressing in place.
There you go. Bandages are used to secure the dressings in place. So here's our dressing. Now they bandaged it up. And now they're applying a splint. Here they padded something up. And so where's the injury at? Joint or not? No joint.
No joint.
No joint.
Okay, so what do we have to immobilize?
The joint above and below the injury.
Run that by me again.
The joint above and below the injury.
All right, so this is the joint above and below the injured site, which happens to be what?
The knee and the ankle.
The knee and the ankle. All right, good. So they checked PMS before, right?
Yeah.
Okay. So they mobilize that, and then what do they do?
Check for PMS.
Check for PMS. So they've secured it again, check PMS. All right, here's different types of splints. Here's a vacuum. So this here's change colors. So here's the vacuum splint right here. There's a pump to take out the air. What kind of splint is this one right here?
For a femur.
Okay, what's it called?
KED.
What was that, Sequoia?
AED.
KED.
No, that's not a KED.
It's a traction split.
What kind of traction splint?
Which one are you talking about, Lou?
What was that?
Which one are you talking about?
The one that's circled in green? Lower left?
Bipolar?
Okay, what's another name for it? It's a bipolar splint, but what's the official name of it?
Isn't that one the hair splint?
Yep, the hair traction splint, HARE. So if that's the hair or bipolar, what's this one over here on the far
The
right?
saber.
The what?
The saber.
No, not saber.
Sager.
Sager, yeah.
What's
bad.
another name for the Sager splint?
I do not know.
It's a unipolar. All right, we have a backboard or a spinal mobilization board, long board. We have the rigid splints, which is basically padding with wood. They hurt. So here's that bipolar. So how much traction do you apply? Did
Wasn't it
everybody
like
get a chance to practice this?
wasn't it like 15% of the body weight?
Nope. You pull on it until the patient experiences relief. How far do you extend this area here? They go over that?
About 8 inches.
Yep. 8 inches past the heel. Here's a vacuum splint. Like I said, they suction out the air, so it's a bag with beads in it. So they enclose the injured limb, strap it down, and then they take out the air, and it molds. And you can see the little beads on them. Like I said, you could use sheets, blankets to mobilize that. So if you don't immobilize correctly, what can happen?
You can damage some nerves, tissues, or more blood vessels.
Okay. Good. So if you don't immobilize properly, then you're risking further injury, and that's what we do not want. All right, good. All right, so here we go again. Immobilizing it, checking PMS. You notice how she's stabilizing it. Another vacuum splint. You see how it's molding? You see how the air has been taken out?
Yeah.
There you go. Better picture of it. Now, they also have, these aren't as bad as the air splints. The air splints, they do the same thing. You inflate them, you put them on, then you inflate it, and it's supposed to immobilize it. But what's the bad thing about using an air splint?
It can cut off circulation.
There you go. When you put that injured limb inside that vacuum, or I'm sorry, inside that air splint, and you apply the air, you're actually compressing on the blood vessels underneath, and it could act like not necessarily a tourniquet, but it could reduce blood flow through that area. So is that really a good thing?
No.
No. Now, for this here, for joints, again, what are we going to immobilize when it's a joint?
Above and below the joint injury.
Yeah, we're going to immobilize the area above and below the joint. Now, with joints, a good idea is to immobilize it in the position found. We want to be very careful about moving joint injuries because we don't want to cause further injury or even further harm. And so we mobilize it in the position found. Do you think this is going to be an easy immobilization?
No.
No. So they used a vacuum splint that worked out pretty good. The other thing you could do is use the those padded splints. You could put a pillow underneath here to have it keep its shape. So, all right. And again, they should be doing both lower extremities, not one. As far as PMS, you want something to compare it to. Now, in general, the muscles in the femur are very tight. They're very stretched out, and so when you have a femur fracture, that's loosening up all that. Not only are we worried about the bleeding, but we're worried about the muscles and the connective tissue in the femur. However, when it comes to a fractured femur, it's going to be a very painful proposition because that is the longest bone of the body. And so imagine the impact needed to break the femur. So is your patient going to be in pain?
Oh yeah.
Yeah. Now, you use either the bipolar or the unipolar traction, and you saw what did you think about the Sager?
It's easier to use or much quicker.
Exactly. So we're trying to pull traction. Now, how does it pull traction? Whether it be the Sager or the hair, how does it pull traction? It anchors down at the pelvis or at the ischium, that leg strap, and then the other end is at the ankle. And what it's doing is it's pulling apart the leg, bringing the femur back into alignment. So knowing that, what are the contraindications for using a traction splint? No idea?
Would it be another injury
Where?
to the same extremity?
Where?
To the ankle?
Lowered?
Okay. Ankle. Knee. Hip. Why? Because remember, it's anchoring down at the hip and at the ankle, and it's pulling it apart. If you have an injury in one of those, how much of a floor are you going to be able to get?
Not much.
Yeah. It defeats the
much.
purpose of using it.
Exactly. So, can't use it in that case. All right. As far as splitting pelvic fractures, some places have. Let me check on something. Okay, almost done. All right. As far as the pelvic fracture, like I said, some agencies have a commercial pelvic splint. A lot of places don't. And you could use some towels, some sheets, some blankets to wrap around the pelvis, bring it together, and anchor it down. And you could even use a mass suit, but again, they're getting rid of the mass suit again. It is a great pelvic splint, but other than that, there's not much use for it. So here's a commercial splint. They put it around the pelvis. They bring in the strings in here, and it helps bring in the sides of the pelvis inward, putting it back into place. Another thing we're worried about with bleeding in a musculoskeletal injury is what we call compartment syndrome. And it's basically what I've talked about the movie Signs, where there's compression there. So the pressure starts to build up, but it has nowhere to go. And so blood flow is compromised. Unfortunately, what happens to that tissue is it becomes hypoxic, it becomes toxic. So we talked about pathologic disease causing weakened bone. And so fractures are a lot more common, easier to obtain. Okay. Any questions on musculoskeletal injuries?
No, sir.
Okay, so again, musculoskeletal, we're dealing with muscles and we're dealing with bone. Muscles, like I said, and the other connective tissue, it's been injured in some way. Tearing, stretching, overstretching, injury to the capsule. Something happened where that muscle, the connective tissue has been damaged or injured. And so really a lot of it is having the person not do too much. The treatment for musculoskeletal, and it's really for both, is what they call RICE, rest, ice, compression, and elevation. So the person needs to be resting it, not putting any weight on it, applying ice. And so be careful about how much ice you put, but you could alternate between ice and heat every couple hours, and usually for about 20 minutes. Compression, putting an ACE wrap on there to help stabilize it. And like I said, elevation, keeping that injured extremity up, not using it. Because what's going to happen or not happen is there's going to be no healing occurring. So you want to make sure that they're not doing too much. You want to mobilize it, tell them take it easy. For other than pre-hospital care on an ambulance, anti-inflammatories can work if they're able to take them. Just remember with anti-inflammatories, they have to be able to eat. As far as bones go, we have dislocations, we have fractures. And the fractures could be either open or closed injuries. What we're concerned about is neurovascular compromise, that the nerves are affected, they're being pinched, or even blood loss or pinching of a blood vessel. If we have neurovascular compromise, what can we do? We could apply unilateral traction one time to try to reestablish blood perfusion and sensation. Okay.
Can you say that one more time, please?
You apply unilateral traction one time. You want to apply ice? You want to get PMS before and after? You want to mobilize? If it's a joint, what do you mobilize?
The area above and below the joint.
Okay. And if it's not a joint, then what do you mobilize?
The joint above and below the injured site.
There you go. And then check, reassess every 15 minutes. You want to reassess the interventions, PMS. And that's about it. Anything else?
No, sir.
All right. So go ahead and take a break. Be back at 10:30.
Sounds good.
All right.
All right. Sounds good.